Good evening to all of you. I welcome you all for the academic activity by Epilepsy SIG. This is the first academic activity by Epilepsy SIG. And today we'll be having interesting case presentation on complex epilepsies, which are managed mainly medically. I would hand over to Dr. Shefali Gulati, our president, to introduce the experts and the moderator for today's session. Over to you, ma'am.
Thank you, Mahesh. So we begin the next SIG of epilepsies, and epilepsy, basically it is a conglomeration of two SIGs in which we've had seizures and epilepsy. We wanted to keep separately, but they had to club them logistically. So we plan to have this first session that have complex epilepsies, interesting cases. I request my colleagues to be very brief and ensure that your students are, brief 8+2, because the idea is just to prime the diverse etiologies and the different spectrum you have. And today we have two wonderful experts, Professor Jitangi, who is professor in pediatric neurology, University of Colombo, and consultant pediatric neurologist at the Lady Ridgeway Hospital, Colombo, and our own alumni, Dr. Puneet Jain, who is currently staff physician, Division of Neurology, University of Toronto, the Hospital for Sick Children, Toronto. Thank you so much, both of you, for joining. And we have the SIG members also who are then panelists, and Dr. Goraya, Dr. Parekh, and many more. So we have so many experts along, and we have all those attendees. So the moderator is Ranjit, and I think he's a very strict timekeeper and a great time master. You don't have to protect his. Everybody knows him. Yeah, he's our alumni. Then he went and got trained with Puneet there, and now he's come back and he's in Ramachandra Hospital. And now he has. It was very nice to see him as a big boss and a teacher there, right? So good. Take over.
Okay. So good evening, everybody. Thank you very much to AOC and Professor Shefali Gulati for giving us this opportunity. This is the first activity from Epilepsy SIG, and all our members are here. So today we will have a session of case presentations about complex epilepsy cases, medical management. Obviously, we are not going to discuss surgical aspects today. So we have a wide range of cases from different institutes across the country. So I would like to start with Dr. Lokesh Shainy's case. The presenter is Dr. Ashna Kumar. She is presenting from AIMS, Jodhpur. So it will be a 6 to 8 minute presentation. At 8 minutes, I will say the time is up, and then we will ask our experts, Dr. Puneet Jain and Professor Jitangi, to give their expert comments. Over to you, Dr. Ashna.
Good evening, sir. Thank you, sir. At the outset, I would like to thank AOCN for providing us this opportunity. So is my screen visible?
It's visible.
Yes.
Okay, thank you, sir. So I'll be presenting a case from AIMS Jodhpur, a girl with acute onset seizures, psychosis, and encephalopathy, thinking beyond NMDA. This was a 17-year-old female who presented to the emergency with chief complaints of fever. That was 15 days back for 1 day, abnormal body movements, 3 episodes in the last 11 days, and altered sensorium from the past 3 days. She had fever for 1 day, 15 days back. That was acute onset, single spike, undocumented, not associated with any rash, chills, or rigors. 2 episodes of abnormal body movements occurred 4 days after the onset of seizures. They were 2 episodes that were separated by 4 hours. The first episode was in the form of a right side deviation of eyes and mouth with tonic posturing of the right upper limb and lower limb, lasting for about 15 minutes, followed by loss of consciousness for 30 minutes. Next episode followed 4 hours later, where she had generalized tonic-clonic type of seizures lasting for 10 minutes, aborted by an anti-seizure medication given at a local hospital. This was followed by loss of consciousness for about 1 hour. At the third episode of seizure occurred about the 11th day of illness. In between these episodes, the child had some altered sensorium in the form of some behavior abnormalities, and this third episode of seizure was also in the form of generalized tonic-clonic seizure that was lasting for more than 5 minutes, for which the child was hospitalized, and this was aborted by levetiracetam, which was given at a health facility, after which the child had impaired consciousness for 4 hours. This was soon followed by altered sensorium in the form of irrelevant talking, behavior abnormalities, and alteration of the sleep-wake cycle. However, there was no associated complaints of any focal neurological deficits, cranial nerve palsies, any sensory disturbances, no history suggestive of any cerebellar signs, no history of any bowel bladder involvement, no history of cough, respiratory distress, any joint pains, rash, photosensitivity, or alopecia. There was no history suggestive of any loss of weight, appetite, recent travel, or bleeding manifestations. Her past history was non-contributory. Family history: she was first born out of a non-consanguineous marriage with no other significant history. She was born by normal vaginal delivery, birth weight of 3.8 kgs with no NICU stay, immunized till age with the normal developmental age. On general physical examination, vitals were stable at admission, anthropometry was normal, and on head-to-toe examination, there was no significant findings, no neurocutaneous markers, no facial dysmorphism, no pallor icterus cyanosis. A focused examination was done, and the CNS examination revealed that she had an higher mental functions. She had altered behavior. She wasn't oriented to time, place, and persons. She had irrelevant speech in the form of incomprehensible sounds. Other components of higher mental functions could not be properly assessed. MMSC could not be done. However, the cranial nerve examination was normal. Her motor examination revealed brisk BTRs with bilateral extensor plantars. Sensory examination, cerebellar signs were not present, and the child had no signs of meningeal irritation. Other systemic examination was within normal limit. This was the video of the child when she presented to us in emergency. We see that the child was in altered sensorium. She wasn't recognizing her parents, and she was restless at admission. Intermittently, she also had abnormal behavior and aggressive behavior. So at the database, we have a 17-year-old female who was first born out of a non-consanguineous marriage with smooth perinatal transition and normal developmental age, who presented with acute onset of fever, 3 episodes of seizures, and altered sensorium, with examination findings suggestive of affected higher mental functions with brisk reflexes and extensor plantars. Based on this history and examination, a set of differential diagnoses that we considered, the first differential being autoimmune encephalitis, because she had a viral prodrome followed by behavior abnormalities and seizures. However, no movement disorder was found. So we thought of limbic encephalitis, anti-NMDAR associated encephalitis, or CDR. Others, we also thought of viral HSV associated encephalitis, as the child had fever, altered sensorium, and behavior changes. Other differentials that we thought of were inflammatory and autoimmune conditions like SLE, CNS vasculitis, and a remote possibility of neurometabolic disorders such as an acute presentation of hyperhomocystinemia was also considered. We sent the investigations to find out the actual cause for the onset of these symptoms, and we found that her TLC was mildly elevated in the range of 19,400 was her total counts. However, the platelets were normal, her LFTs, KFTs were within normal limits, the electrolytes were normal, her CRP was 7.8 with an ESR of 12, the coagulation profile was normal, and a workup of tropical infections was negative. ANA, TFT, and anti-TPO were all within normal limits. We did a CSF examination, and cytology did not reveal any cells. However, biochemistry revealed a mildly elevated protein count of 60 and glucose was 51. Her CSF cultures were negative, and her HSP PCR was also sent, which was awaited. Meanwhile, we also sent her autoimmune panel, keeping a strong possibility of autoimmune encephalitis. We went ahead with the CT head that was grossly normal, and an EEG at admission was done, which revealed that there was diffuse slowing which was present, as we can see on the left side, more on the posterior areas, and also some broad-based discharges that could be seen on the temporal areas. Her MRI was done, which was suggestive, showed showed left-sided T2 and flare hyperintensities in the superior frontal gyrus. Also, there was some diffusion restriction, which was present in the thalamic area. There was mild bulkiness of the hippocampus. However, the contrast T1 image was normal. So we had this child who had altered sensorium and seizures, which were controlled on anti-epileptics. Her MMSC at admission could not be done. CSF was normal, culture was sterile, CECT was normal. MRI brain revealed the findings of signal intensities in the amygdala, left temporal gyrus, and the claustrum. And keeping the possibility of HSV encephalitis and waiting for the results of HSV PCR, we started her on injection acyclovir. However, we were considering a strong possibility of encephalitis. So once the CSF was normal, we started her on pulse steroids that were given. Even after 2 days of pulse steroids, the child continued to have behavior abnormalities. So we wanted to treat it aggressively, and we gave her IVIG also simultaneously at 2 grams per kg. Meanwhile, her autoimmune panel report came out to be negative. Her NMDA was negative, and HSV PCR for CSF came out to be negative. This was the video of the child when she was admitted with us in the ward. We see that the child was still encephalopathic. She started to have some improvement post steroids in the form that she was vocalizing, recognizing her attendant, but still her behavior was
Hi,
not
Dr.
normal.
Ashna, you have 2 minutes.
Sure, sir. So we went ahead with the paraneoplastic panel also, and we found that ZIC4 antibody came out to be strongly positive. Meanwhile, her MMSC started improving from not being assessed at the baseline to 13 at day 9 and then 22, and it was 30 at about day 13. Once we reviewed the literature, we did not find any case report from pediatric age group of ZIC4 antibody. However, in adults, it has been strongly associated with small cell lung carcinoma. So we actively searched for any focus of malignancy that could be present. Her USG, abdomen and thorax was normal. However, CECT, thorax and abdomen revealed mild bilateral pleural effusion. So a final diagnosis of ZIC4 associated autoimmune encephalitis was done, because even after the immunotherapy, once we sent the paraneoplastic panel, it came out to be strongly positive. However, we kept the child under close surveillance, and we went ahead to go with the PET scan to find out if any hidden focus that we are missing. And the PET scan that we found had increased focal intake in the uptake in the left apicoposterior segment of the left upper lobe of the lung, with minimal right pleural effusion, with associated increased uptake in bilateral temporal lobes, basal ganglia, and left thalamus. So finally, this was a diagnosis of ZIC4 associated autoimmune encephalitis. We reviewed, and it is an intracellular protein that has a zinc finger domain that is important for CNS development, and it has been most commonly associated with cancers. Most reports are from the adult age group, associated with small cell lung carcinoma being the most common, and other associations being with thyroid carcinoma and head and neck cancers. We had reports of about 15 patients, all from adult age group, and small cell lung carcinoma being the most common. Our child also had some investigations which were suggestive of this, so we have kept this child under close surveillance. This was the child when she presented to us after discharge at about 1 month of being treated, and we see that she is fine. She was interacting well. Her MMSC was 30. She was responding to all commands, and her EEG at 1 month follow-up showed that it has normalized. Her rhythms had improved. There were no slowing
Dr.
and
Ashna,
no focal discharges. Yes, sir. Finally, my take-home messages from this presentation is that appropriate history and examination is a clue to correct diagnosis. Autoimmune encephalitis should be identified early and treated to have a favorable outcome. Even in cases where we do not get a positive serology or there is no antibody to suggest, immunotherapy on the basis of clinical suspicion can work wonders. Detection of specific antibodies can help us to predict the future course and help in surveillance and timely detection of the hidden malignancies. Thank you.
Thank you, Dr. Ashna. That was a very nice case. Any
Thank you,
comments from our experts? Professor Jitanki?
Ranjit was the faculty.
Oh, sorry, ma'am.
Faculty.
Yeah.
Ah.
Yeah, Dr. Lokesh. Yeah, moderator. Yeah.
Yes. Good evening, ma'am. Good evening, Ranjit. So this was a interesting
Good
case.
evening,
Actually, good evening, ma'am. We are the this is the first, and we did not believe that first this is positive, because it all are adult reports. But seeing that there is a hidden malignancy also, there is a raised suspicion after PET report, that, and especially lung carcinoma, then we did think that this is not incidental, and it is actually the child is having these symptoms.
Lokesh, please answer this question. What was the treatment for apical lung malignancy? पढ़ते जाओ अपने आप बोलते जाओ to save time.
So yeah, quickly.
Yeah. Ma'am, right now we are in discussion with the tumor board of our hospital tumor board, and they will be deciding treatment, ma'am, of this condition.
So where did you send the paraneoplastic panel? There was one question. Yeah.
To NIMHANS, right? And we did this and this for this child at NIMHANS only.
I'm expert.
Now the experts. Yeah.
Professor Jitanki, ma'am.
Hello, can you hear me well?
Yeah, yes.
Yeah.
So thank you very much to AOC for having me, and actually very interesting case, and congratulations on your diagnosis. I have to confess that actually I have no experience with the SIG4 antibody encephalitis. But if you just go back through just the basics, I think, our thought process of approaching a child who comes with this type of like febrile illness associated with seizures and also associated with status, and also the predominant behavioral disturbances. I think you quite rightly like had a very rational approach. You consider the infective origin. One comment I would make would be like, I would probably consider other viral illnesses as well, just not only the viral encephalitis. So if I have the, like, I don't have the prestige of the investigation capacity that you have, but one other differential diagnosis that I would entertain would be other viral illnesses. And also, I just noted that, in your general counts, you had a platelet count of 100,000, right? So just 100,000. So I would have been a bit concerned, like your total count was high, you had a thrombocytopenia, I would be looking for other parameters to see whether there could be any other viral illness as well. And also for me, like NMDR antibody status would be like the positivity rate would be maybe between about 30 to 40%. So just the absence of NMDR antibodies may have not made me exclude that entity on its own. As you say quite rightly, like, most of the cases are not reported in children. Doesn't mean that it is not possible in children, but I think the clue came because you had the you had the facility to identify this antibody. So I think, it just highlights the rational approach to a clinical case. And as you quite rightly said, even whether the antibodies are positive or not, it's a diagnosis that we would consider. And there's always the probability that you can consider the diagnosis of probable autoimmune encephalitis. And then in this case, the fact that there were seizures also made me consider whether this was NMDR, like encephalitis, like the cortical encephalitis presentation, because there were predominant changes that we could see in the MRI. So I may have considered that as well, because it was more unilateral. So I would have, wondered, could it have been NMDR cortical encephalitis kind of presentation? The other factor that I actually wanted to ask you was, what really happened to the PET finding? Like, did you chase behind the PET finding that you found in the lungs? So did the child actually have evidence of, like, did you have biopsies performed from those sites? I just wanted to know what was the outcome from the PET finding. So that's a question that I would want to, find out about the patient.
Dr. Lokesh?
Hello, can you hear me, Ranjit?
Yes.
Yeah. Thank you, ma'am, for the comments. Actually, ma'am, we are in the stage of we are in the consult of medical oncology team, and they are planning all these things, biopsy and all. PET finding shows that there was a X-ray in CT initially showing pleural effusion, and since pleural effusion came and there is a strong association with lung carcinoma, we went ahead with PET, and PET also shows that there is hypermetabolism and pleural effusion there, which is persisting despite the child has improved. So now, because there is strong suspicion of malignancy, now biopsy will be planned and further thing in the tumor board discussion now.
Thank you. So I think, excellent diagnosis, and then probably this would have led to early detection of the carcinoma in the patient.
Thank you, ma'am.
Thank you.
Dr. Puneet, any quick comments?
Thanks, Ashna and Lokesh, for presenting a very well-managed and worked-up case. Just a quick comment that in our experience in these children with autoimmune encephalitis, we frequently find a very high load of electrographic seizures, even when clinical seizures have been controlled. So obviously, there's a role of more frequent EEG monitoring, especially in the acute phase. Continuous EEG is obviously desirable, but if facilities are not available, at least getting a quick spot EEG on a frequent basis would be desirable just to make sure that the child is not seizing electrographically. Just a quick comment.
Thank you.
Thank
So
you,
we'll
sir. Thank you, sir.
Yeah.
Will do.
So we'll move on to the next case. This is from our institute, Sri Ramachandra Institute at Chennai. I would like to request Dr. Sanyukta to present the case.
Ashna, this will be mailed to you. This certificate will be mailed to you.
Okay, ma'am. Thank you so much.
Thanks for a wonderful case and wonderful presentation.
Dr. Sanyukta, over to you. Yeah.
Yes, sir. So is my slide visible, sir?
Yes. Go to presentation mode, slide. Yeah.
Good
Yes.
evening, everyone. I am Dr. Sanyukta Godke, second year pediatric postgraduate. I'll be presenting an interesting case titled Dousing the Fires at its Source under Dr. Ranjit Kumar Manokaran, consultant pediatric neurologist and epileptologist at Sri Ramachandra Institute of Higher Education, Chennai. An 8-year-old child, product of non-consanguineous marriage, developmentally normal child, developed super-refractory status epilepticus. The provisional diagnosis of Fires, receiving treatment from outside hospital, was referred to our institute for further evaluation. Let's go into the birth history of the child. There were no adverse events, no NICU admissions. Developmentally history-wise, the child, all the milestones were achieved at appropriate age without any delay. The child was immunized up to date. A premorbidly normal child developed multiple seizure episodes 4 months back. Seizures were in the form of episodes of unresponsiveness with deviation of head towards the right with shivering of right hand. Few episodes also started from the left side also. The child was treated at outside hospital and was started on multiple anti-seizure medications and antibiotics like ceftriaxone and vancomycin. The GCS of the child at this moment was 9/15. In spite of multiple anti-seizure medications which were administered, seizures didn't subside and progressed to super-refractory status epilepticus. MRI and EEG which was done was non-revealing. A lumbar puncture was also done and it ruled out any CNS infection. By this time, child was on multiple anti-seizure medications like phenytoin, topiramate, levetiracetam, clobazam, sodium valproate, lacosamide, phenobarbital, midazolam, and thiopentone infusions. Provisional diagnosis of Fires was made by this time. Child was then administered methylprednisolone for 5 days, immunoglobulins, tocilizumab in view of increased serum interleukin-6 and plasmapheresis of 2 cycles. Child was tracheostomized on day 26 of illness. EEG done showed generalized periodic discharges. Child was also started on ketogenic diet and got discharged from the hospital at request. Child was then received in our institute with GCS of E1, VT, M1 on day 30 of illness. This is a graphical representation of summary of events before we received the child in our hospital, right from initiation of methylprednisolone, tocilizumab, initiation of ketogenic diet, and also 2 cycles of plasma exchange therapy, which was given. On arrival, child had near continuous seizures. Child was already tracheostomized. High-grade fever spikes were present with the GCS of E1, VT, M1. Due to chronic illness, child had various other problems such as pressure sores, critical illness neuropathy, and ventilator-associated pneumonia. After arrival, we did a neuroimaging MRI contrast, which showed mild dilatation of the ventricular system, suggesting chronic atrophic changes. An interictal 18 FDG PET scan was done for the child, which showed bilateral parieto-occipital hypometabolism on PET scan. You can see the hypometabolism over here. This is one of the EEG which we did for the child, and it showed nearly continuous semi-rhythmic sharp wave discharges, which were more on the left side than on the right side. We did CSF analysis for the child, and the CSF count which we did was normal. Sugar, protein, chlorides were normal. CSF culture was sterile, and a pan-viral PCR which was sent was also negative. A paired serum and CSF sample for autoimmune epilepsy panel was also sent, which was negative for the child. In the meanwhile, we also optimized the ketogenic diet dose. We also started the child on high-dose phenobarbital, followed by maintenance at 10 mg per kg per day. Other anti-seizure medications were also continued by this time. In spite of this, the super refractory status epilepticus still persisted. We had few limitations, like anakinra, which is an interleukin antagonist, was neither available nor affordable. Purified CBD oil was also not available. Vagal nerve stimulation, continuous EEG was not affordable by the parents. CSF interleukins and neopterin levels were not performed as they were not available. We went through the literature and we found this article, which was performed, the study was performed in Japan. They used intrathecal dexamethasone therapy for febrile infection-related epilepsy syndrome in children who did not respond to other modes of treatment. Further, in view of, with parents' consent, an intrathecal dexamethasone was given at a dose of 0.25 mg per kg per day. The treatment was repeated 4 times and the dosing interval was 1 day. So it was performed on day 1, 3, 5, and 7. On day 0, when we received the child had approximately 25 to 35 seizures per day, which were reduced to 10 to 15, and the child was seizure-free post dexamethasone therapy. There were few seizures occurring breakthrough through intercurrent fever spikes, though. I would like to share this video. On discharge, 2 weeks later, after the dexamethasone therapy,
Yeah, Dr. Sangeeta, just 1 minute more. Yeah. One minute more. Yeah.
oh, yes. The exact cause of fires is not known. Metabolic, microbiological, genetic, and immune analysis are unrevealing. Mutations in genes associated with fever-sensitive epilepsy, such as SCNIA, Dravet syndrome, and PCDH119, or in genes associated with infection-triggered encephalopathy and status epilepticus are typically absent. It is also possible that the syndrome is caused by an inflammatory or an autoimmune mechanism. High levels of pro-inflammatory cytokines and chemokines have been found in the serum and CSF of children with fires, suggesting a role of immune system in this condition. Sorry. Intrathecal dexamethasone also helps in reducing the cytokine and pro-inflammatory levels. In our case, temporal resolution of seizures following intrathecal dexamethasone and multimodal therapy for super refractory status epilepticus resulted in a favorable outcome. Further multicentric studies may provide more conclusive evidence for this. My take-home message will definitely be intrathecal dexamethasone represents a therapeutic option for patients with fires that could shorten the duration of the critical stage of the disease. The sequence of initiation of intrathecal dexamethasone during the course of fires, which could be very early, or late, needs further exploration. Thank you. I would like to thank the patient's family and our PICU team. Thank you so much.
Yeah, thank you very much, Dr. Sanyuta. I appreciate her. She's a pediatric PG, one among the DM residents here. So just
Your comments. Your comments.
Yeah, my comment, ma'am, like I think there is a slide which highlighted the limitations in our setup. So I think Dr. Puneet will give a lot of comments on that, like we don't have anakinra easily available and continuous EEG in our setup. That was a limitation. And I think a lot of questions about the preparation. I don't think we have this preservative pre-preparation. It did contain methylparaben, the usual preparation. So we discussed with the pharmacy and ICU team and the family. We went ahead with that. We didn't face any side effect, at least in this case. So we just gave 0.25 mg per kg every alternate day, 4 doses we gave. So right now, child is on tracheostomized and his sensorium is not that great, although he's kind of in a vegetative to minimally conscious state. At least he's kind of his seizures are passive. So that's his current state.
Is on KD also?
He is on full KD, ma'am, 4:1 ratio.
Okay.
On EG2. So
okay, besides Dr. Puneet and Dr. Jitangi, Dr. Biju is also there. So Dr. Biju can also comment after they have come, please. Request Dr. Biju to also. Yeah.
Dr. Puneet, I would like to. Yeah.
Thanks, Ranjit and Sanyukta, for bringing this case. Clearly highlights the struggles that we have with patients with fires. I think the case was very well managed. I'll have just 2 quick comments. One, I think more recently we have had some encouraging results with the use of ketamine infusion in our patients with fires in acute phase. So that can be one of the alternatives that can be used besides phenobarb, midazolam, thiopentone. And 2, I would say that very heartening to see the response to intrathecal DEXA. We recently used intrathecal dexamethasone, I think, for 2 of our cases with these fire/autoimmune encephalitis cases. And we had very modest responses to these therapies. So just a brief experience there. Thanks again.
Dr. Biju, any comments? Thanks, Dr. Punitya.
Dr. Biju, your experience with anakinra and all?
Anakinra, yes, but steroids we haven't used. I was just looking while the presentation was going. I was just looking at the literature. I think some other group has also from Rochester has also presented a case on intrathecal dexamethasone in fires. Interesting. And I wasn't aware about the methylparaben which Kavita mentioned. It's very important here. But we haven't used it. I don't think Helen has used it here. Of course, DBS would be another option. I think we've done 2 at Ghosh with good results.
And actually, we are comfortable with phenobarb coma. Actually, many people don't give, but at teams like we developed a protocol, and I think it works because with others you have to get the anesthetist on board. So we don't have that much of support. So that is something what we can do. That's why we had developed our own protocol and all, and so I think it works well. I mean, besides KD obviously yes, and we've had some good responses, some not so good also, but some really good ones also. Jitangi, you must be also facing fires, right?
Yes, we do, but probably not in the usual number, about 1 a year, who comes, with the, usual presentation. So excellent case, just highlighting the, usual salient clinical features, the age of onset, the presentation, and then I think some of the seizure details might, help us to identify the fire syndrome. I think Puneet did mention about use of ketamine. I think several centers have described their, experience with ketamine. So probably, but still, I don't think we have, enough evidence really to say that ketamine is effective. It's just that in some series, ketamine has been found to be useful. But I think though you did not have anakinra, you did use tocilizumab very early in the course of the illness. So identifying the role of the immune activation, the activation pathway, the T cell activation pathway early, and trying to manage the cytokine storm is the key factor, I think, when you use immune therapy. So I although we all have limitations. I don't have most of the drugs that you have used. So I think it's identifying the syndrome and trying to use the appropriate immune modulation that is important. And I think this child, it's heartening to see the response, so which probably is, more and more of us would be using dexamethasone intrathecally with these experiences. But it seems that, we are seeing the same outcome that we see in most of the patients with FIRES, the final outcome, where invariably all of them end up with the outcome with long-term epilepsy, and also the cognitive, outcome that we saw in this patient as well. So interesting case, and thank you for sharing.
Thank you, ma'am. Thank you very much for all your comments. I think like in our setup, affordability issues, like DEXA is a very cheap and easy option. So I think this needs to be explored, and also the timing, early versus mid course versus late course. Okay, so without wasting much time, I will go to the next case. I request Dr. Aarti. She is from Amrita Institute. Her guide is Dr. Vaishak Anand. Over to you, Dr. Aarti.
Thank you, sir. Am I audible?
Yes.
Yes, audible.
Yes, sir. Yes, sir. Just switching to slideshow. My slides are visible, sir?
Yes, it's visible.
Yeah. Good evening to one and all present here. I'm Dr. Aarti, DM resident, pediatric neurology from Amrita Institute of Medical Sciences, and I'm going to be presenting this case under the guidance of Dr. Vaishak Anand, sir. So our presentation is titled "Killing two birds with one stone." Just a second. Sorry.
I think, Ranjit, you should please note down all the titles of all presentations.
Yeah. Yes, ma'am. Yeah.
These seem to be interesting. Even you're dousing the fire and all.
Yeah. Sorry, ma'am, for that slight glitch. So this was a 2-month-old boy, second born of a non-consanguineous marriage. They were actually from Maldives and delivered by a full-term LSCS, 3.6 kg at birth, cried immediately, and no perinatal events. The parents had, however, noted hemangioma involving the entire pelvis and bilateral lower limbs since birth. And the child was noted to have unusually chubby cheeks. And hyperpigmented streaky lesions were noted. So he was brought with regards to this hemangioma at 2 months of age, and there were no major issues then. Anthropometry was okay. The general examination revealed streaky pigmentation and chubby cheeks. There was a left hemihypertrophy as well. Extensive hemangioma extending from below the umbilicus, involving the posterior and the anterior aspect of bilateral thighs, and entire legs were noted. The initial impression was which was probably a vascular malformation with left hemihypertrophy. The child basically was brought to us at 3.5 years of age with seizures. Then the semiology was suggestive of a GTCS lasting for 25 minutes, and the child was initiated on sodium valproate and levetiracetam at a local center in Maldives. When he was brought, then there was GDD noted. He could only stand with support, could scribble, and the total vocabulary was only around 10 to 20 words. Examination here revealed macrocephaly, which was a new finding here, and the venous vesicles were noted over the right lower limb with occasional bleeding, and there was extensive capillary hemangiomas noted over the body, and there were nevi noted over both the cheeks and left upper limb as well, and there were bilateral lower limb hypertrophy was noted, left more than right. This is the clinical picture. As everybody can appreciate, there are unusually chubby cheeks and this streaky hyperpigmentation that is noted, and extensive hemangiomas also noted over the lower limbs. So the investigations, we went ahead and got an MR imaging done for this child. And as you can see, the first sagittal view showing some scalp hypertrophy, and the axial MRI will also very, very obviously suggesting cheek hypertrophy, left more than right. The axial images here suggest a polymicrogyria, and you can see here in the left one that there are these band heterotropias are also noted. The signal changes are visible, and there are dilated ventricles noted as well. The SAG views here are showing that the CC is basically foreshortened, and there is a posterior fossa, some crowding is noted. Along with that, these coronal and axial cuts here that show some scalp hypertrophy and the polymicrogyria, very obviously visible here. Along with that, there is an asymmetry that was noted in both the hemispheres. An EEG was done for this child, which was showing generalized fast activity suggestive of cortical malformations, and left frontal spikes were noted as well. So the syndromic diagnosis at this point of time was basically that we had kept, it was like a hemihypertrophy and a regional overgrowth syndrome. There were capillary malformations and epidermal nevus, and the child had epilepsy and global developmental delay. So the differential diagnosis considered at this point were probably it was a megalencephaly, capillary malformation, polymicrogyria syndrome. Neurofibromatosis was also considered as a DD, and Proteus syndrome. So a whole exome sequencing was sent from peripheral blood, which was normal. And a skin biopsy was taken from a soft overgrowth over the abdomen and sent specifically for PIK3CA mutations. Awaiting the biopsy results, actually, the child was noted to have 3 brief seizures that were suggestive of hypomotor events and 1 GTCS event while he was already on 2 anti-seizure medications. The genetic analysis of the skin biopsy actually revealed PIK3CA in a low mosaic state, 5% cells detected in exon 2. And basically, our final diagnosis was a PIK3CA mosaic leading to megalencephaly, capillary malformation, polymicrogyria syndrome. So the cause was basically this child, upon consideration with the genetics team here, was initiated on sirolimus at 0.25 mg BD, that is 1/4 tablet, 1 mg 1/4 tablet, and the dose was basically titrated based on the trough serum sirolimus levels. He had 2 brief seizures after the initiation of sirolimus. However, he's been seizure-free over the past 1 year. There are no adverse effects noted. We are frequently testing him and nothing yet. Subjective improvement was reported in the behavior as well as development, and currently this child is 5-year-old, seizure-free since the last 1 year. So a little bit about PIK3CA disorders. Basically, it is a PROS, that is the PIK3CA related overgrowth spectrum, one with related vascular malformations and related non-vascular lesions can be noted. Looking at the mTOR and the MAPK pathways, basically there are 3 pathways that are involved here. One is the RAS and RAP pathway that can be that is involved, the mTOR, PIK3CA and AKT, and the third being a GATOR pathway. So basically under PROS, that is
1 minute more. Yeah.
Yes, sir. Yes, sir. I'm just going to quickly skip over this slide. Basically, this the PROS can basically be MCAP and non-MCAP, along with there can be epidermal nevi, macrodactyly, sebric keratosis also seen. What is basically the precision medication targets that are basically your mTOR inhibitors are available. Sirolimus was initially the first one, that was actually the first molecule found out here, rapamycin, everolimus. PIK3 inhibitors, alpelisib, however, these are not available in India, and AKT inhibitors also, like miransatine. So these may act like precision medication targets. A little word about sirolimus, that it is basically, it's an mTOR inhibitor, and trials stating that everolimus can be used as an adjunctive therapy for resistant seizures have been noted. However, there is no trial comparing sirolimus and everolimus. But everolimus, as we know, is very, very expensive, and comparatively, sirolimus is a better alternative. However, everolimus has a good oral bioavailability and a better adverse effect profile compared to sirolimus. This, as we all know, is the EXIST-3 trial that used that extensively.
Dr. Aarti, time up. Yeah.
Yes, yes, sir. Yes, sir.
You will just show the take-home messages and
yes, sir. Yes, sir. Yes, sir. So basically, a PIK3CA mutation should be suspected in epilepsy-associated cases with capillary malformations, any regional overgrowth or epidermal nevus. And in suspected somatic mosaicisms, often your peripheral blood may be negative, so you would have to send samples using a skin biopsy or from the vascular malformations. Sirolimus may be tried in epilepsy that can be associated with mTOR pathway mutations, and adverse effects are relatively high. And there are robust trials that are needed actually to prove that sirolimus can also be used as an adjunctive therapy. Thank you. Thank you, sir.
Thanks, Dr. Aarti. Dr. Vaishak, comments from you.
Thank you, Dr. Arti, for that concise presentation. So both this condition and this drug, both are not that familiar to us as pediatric neurologists. This gene PAK3CA is upstream of the mTOR in the mTOR pathway, which we are all well familiar, which is involved in the tuberous sclerosis. But unlike tuberous sclerosis, in this condition, the somatic overgrowth and the vascular malformation, these are the most striking features rather than the seizures and epilepsy. But since the pathway is common, it made sense that the mTOR inhibitors may work well in this condition like TSC. So that's why sirolimus was started. Actually, it was started from our genetics team because it was started not for seizures but for the somatic overgrowth. Because there are some studies demonstrating that sirolimus can lead to reduced growth in these PIK3A related somatic overgrowth syndromes. But related to seizures, the data is very sparse because this condition is mostly described in the genetic and oncology literature. So the data is yet to come, but in this case, actually, after starting sirolimus, although it was not specifically started for the epilepsy, it controlled the seizures also very well. So I want to thank our genetics team, Dr. Sheila Nampudiri, also for this case.
Yeah, so I would like to start with Dr. Puneet. I think he likes mTOR and those genes so a lot. Yeah.
Thanks, Aarti and Vishak, for a very nice presentation, a great example of precision medicine. I don't have much to add, but I'll just say that now more and more centers have started doing somatic testing in patients with cortical malformations who are undergoing epilepsy surgery at different centers, but still not widespread present even in this part of the world. And I'm sure with more somatic testing, we'll find more of these mTOR pathway genes getting involved in these cortical malformations, and more targeted therapies will come up in future. So thanks for presenting this nice representative case.
Professor Jitanki, any quick comments?
I don't have anything to add. Nice case, Dr. Aarti. Just one question that I had, were the cortical malformations also very unilateral, or, considering the mutation, I would have expected there to be more bilateral lesion. So what was the finding on the MRI?
It was bilateral, ma'am. The polymicrogyria as well as the band heteropia, they were bilateral. So the surgery was out of the question initially itself.
Yeah, thank you.
Dr. Biju, any quick comments?
No, interesting case. Nothing more to add.
So, Vaishak, one quick question from Dr. So can you use metformin instead? Is there any role of metformin?
Yeah, so there are many case reports regarding metformin, propranolol, and all. Propranolol, as we all know, is usually used in capillary hemangiomas and all. But that literature all comes from the genetic, dermatology, oncology literature. Pertaining to the epilepsy per se, there is not much reports to mention that will act on the seizures or epilepsy per se. And the mechanism wise also, we cannot expect that it will have an anti-seizure efficacy.
I beg to differ, Vaishak. We've actually just had an ethics approval. We have to start a trial, which we were starting between Vishal Sondhi's site and Lokesh Saini's site and our site, because there are studies going on which says, that metformin may be useful for an anti-seizure medication. So that has been tried. They're also trying to study 2-deoxyglucose. They're also doing trihepatoin. So they're trying to see other things, trying to understand. That's why so that there is a thing. So metformin, we have not done it right now. We have not started the enrollment. But that is there. But it's not a classical. You're right in that way. There is not a classical ASM, but it is being used for in some studies. It has been showing. So we will also be trying. So probably we'll be able to do. Lokesh is on the call, so we can just talk after this and start the recruitment. Yeah. Basically, we're waiting for Lokesh Saini's site to have ethics approvals. We'll talk about after the session. Thank you.
Thanks, Vaishak.
Thanks. Very nice case. Very nice case. Yeah, very nice case.
Yeah, so we are also using sirolimus in patients with SEGA who cannot afford everolimus. Okay, I'm moving to the next case. The presenter is Dr. Sai Monica, and this is from Dr. Sangeeta's team from CMC Velu. Just 1 second. Dr. Puneet is going to leave soon. Shafali ma'am, yeah.
Sorry, I have to push to next meeting at 11:30 here. But thank you so much for having me here. And
you have 6 minutes, right? 6 minutes?
Yeah,
more?
yeah.
Yes.
I'll still
about this one case, Dr. Puneet. Just
Okay.
quickly this case. Yeah.
Yeah, well, thanks for joining, Puneet, in any case. Thank you so much. Thanks. We look forward for more interactions. And
Thanks so much for having me.
yeah, thanks.
Is my screen visible, ma'am?
Yeah.
Yes, Mona. A very good evening to one and all, to all my teachers and colleagues here. I'll be presenting one of the treatable genetic epilepsy under my mentors Sangeeta ma'am and Maya ma'am. I would like to start with the case. 2-year, 10-month-old boy, first born to non-consanguineous parents with insignificant antenatal and perinatal history, presented with seizures since 2.5 years of age and regression of language predominant milestones. His development history, he had global development delay with regression of the milestones since 2.5 years of age. He presented at 2.5 years with fever-provoked and unprovoked generalized tonic-clonic seizures with a frequency of 6 to 8 episodes per event day and 2 to 4 event days per month. And he presented to us by 2 years, 10 months of age, when he also had the regression of language skills and autistic traits. So he was being treated by anti-seizure medications like levetiracetam, valproate, clobazam, and lacosamide. This is the pedigree chart, and there was positive family history. His paternal uncle and aunt had simple febrile seizures. On examination, there was poor anthropometry was normal. He had poor eye contact, hyperactivity with motor stereotypies, and other examination was normal, and systemic examination was non-contributory. So the provisional diagnosis, which we thought was global development delay with regression of language skills and genetic epilepsy with febrile seizure plus. This is the EEG done at presentation, that is 2 year, 10 months, which was frequent spike and sharp wave and slow wave discharges seen over both frontal and right anterior temporal mid-frontal regions with preserved sleep markers. Imaging was normal. Genetic analysis revealed heterozygous missense variation in exon 17 of SEN2A gene that results in the substitution of tyrosine to aspartic acid at codon 927, leading to DE11 phenotype, which is inherited in an autosomal dominant manner and considered to be likely pathogenic. There is also another mutation detected in the exon 1 of NBA. However, it is variants of uncertain significance. Validation by Sanger sequencing revealed both mother and father were wild type to SEN2A. The presence of this de novo is likely pathogenic variant in SEN2A confirms the diagnosis. So finally, he had again followed up at 4 years of age, and he was found to be seizure free since then. So he has global development delay. However, there are gains in motor milestones, and autistic traits continue to persist. His EEG is normal. So the anti-seizure medication which we added at the presentation 2 years, 10 months of age was phenytoin, apart from the other drugs, that is levetiracetam and clobazam. I would like to present the second companion case, who is a 6-year-old boy, first born to non-consanguineous parents with insignificant antenatal risk factors. The perinatal risk factors include preterm, low birth weight, delayed cry at birth. He also had delayed attainment of milestones, predominantly language and socio-cognitive domains, and followed by regression of the milestones since the onset of seizures, that is at 18 months of age. As we can see the timeline, he initially presented with seizures at 1 year, 6 months of age. The semiology was unprovoked generalized tonic seizures at the frequency of 1 to 2 episodes per event day with 1 event day per week. And he also at the same time started to have regression of language and socio-cognitive skills. He developed autistic traits at around 3 years of age. And the anti-seizure medications that were going on till 3 years was phenytoin, oxcarbazepine, levetiracetam, and clobazam. However, he was seizure free for a period of maximum duration of 9 months, but then again near 3.5 to 4 years of age, he started to develop seizures of the various semiologies characterized by generalized tonic-clonic seizures, left focal to bilateral tonic-clonic seizures, focal non-motor seizures characterized by vacant state with perioral automatisms, and he had gait imbalance with worsening of these seizure frequencies and sleep disturbances. So he was treated with phenytoin, levetiracetam, oxcarbazepine, clobazam, zonisamide, valproate, brivaracetam, and steroids at 5.5 years of age. And he presented to us at 6.5 years of age, where we have optimized the anti-seizure medications. Examination revealed microcephaly with poor eye contact, auditory agnosia, hyperactivity, variable tone. He had variable tone, and there was ankle clonus. The provisional diagnosis was global development delay, predominantly affecting the socio-cognitive domains than the motor system, than the motor domains, with microcephaly, autistic traits, refractory epilepsy. Neonatal risk factors include preterm, low birth weight, and birth asphyxia. So, considering the neonatal risk factors, we have also considered either structural or the genetic epilepsy. But as we see here, predominant socio-cognitive delay rather than the motor milestones, we had also considered the genetic epilepsy as one of the differential diagnoses. EEG showed continuous spike wave and slow wave sleep with poorly formed sleep markers, and MRI revealed mild period changes. Genetic and whole exome sequencing revealed heterozygous single base pair insertion in exon 12 of SCN2A that results in the frame shift and premature truncation of protein 9, 9 amino acids downstream to the codon 484, which is inherited in an autosomal dominant manner. And it is considered to be pathogenic. And there is also one more mutation detected in exon 4 of GAB-RA1, which however is variability of uncertain significance. Validation done by Sanger sequencing revealed both parents for wild type for this SCN2A mutation, and this is considered to be a de novo variant. So coming to SCN2A is the second most common, next only to SCN1A, which is the first reported causative gene for epilepsy. The first identified inherited mutation seen in self-limited autosomal dominant epilepsy syndrome, benign familial neonatal infantile seizures. So I would like to briefly tell about the various voltage-gated sodium channels. So we have 9 isoforms in the CNS, out of which the voltage-gated sodium channel 1.1,
we have 2 minutes.
Okay, sir. 1.3 and 1.6. So SCN2A encodes the voltage-gated sodium channel 1.2, which is present in the initial part of excitatory neurons. And this is the voltage-gated schematic diagram of the voltage-gated sodium channel, which has a beta unit and an alpha subunit. So this alpha subunit again has 4 domains. It is, and this SCN2A is present in chromosome 2q24, and these neurons are predominantly present in cortex, hippocampus, striatum, midbrain. Most of the mutations are missense mutations inherited in an autosomal dominant manner, and there are few recurrent variants like B261M, R853Q, and so on. So I would like to just tell about the difference between gain of function and loss of function mutation. So the gain of function is usually because of a missense mutation where the onset of seizures in early in life, and in 20% cases we see autism, whereas loss of function is usually because of the truncating mutations and stop codons where seizures onset in the later part of life, and majority have behavioral disturbances, autism. It has been classified as neonatal infantile epileptic encephalopathies, benign infantile seizures, which is usually because of gain of function mutations, and other autism spectrum disorder with development delay with or without epilepsy and late onset epilepsy is usually seen with loss of function mutation. So the various phenotypic spectrum we see include febrile seizures plus benign familial infantile epilepsy, benign neonatal epilepsy. West syndrome and Atara syndrome are seem to be more common, followed by early infantile epileptic encephalopathy, and more than 2 years the unclassified variants are most common. So the seizure semiologies include asymmetric tonic seizures with versifeatures, hemiclonic seizures, hypomotor seizures with autonomic features, epileptic spasms, and 80% are known to have development delay. Other phenotypic spectrum includes movement disorders like dystonia, chorea, episodic ataxia, auditory startle, strabismus, shuffling gait, optic atrophy, and non-neurological manifestations include constipation, GERD, respiratory manifestations like episodic hyperventilation, breath holding spells, tachycardia, and temperature instability as autonomic manifestations. So in the study conducted, they have shown that the severity of phenotype, it depends upon the severity of gain of function mutations, which is detected by the dynamic action potential clamps. So it means that the same variant can cause early onset as well as late onset. So the genotype does not predict the outcome severity in early infantile phenotypes. EEG includes burst suppression pattern, slow disorders diagram. I'll just conclude.
You complete it. Take another minute and complete. Yeah.
Multifocal interictal epileptiform discharges. So this is the diagram showing the burst suppression pattern, and this is the imaging which includes which shows cerebellar atrophy, hypermyelination, absent corpus callosum, under-operculization. Anti-seizure medications tried include phenytoin, oxcarbazepine, carbamazepine, valproate, topiramate, levetiracetam, and we have seen that ACTH has shown to exacerbate seizures. So phenytoin especially is useful in gain of function mutations with a dose of 4 to 15 mg per kg per day can be used with the supratherapeutic levels of even more than 80. And the factors related to poor prognosis include de novo variants, abnormal MRA findings, and drug-resistant epilepsy in moderate to severe DE seen in 40 to 100% of the cases. To summarize, SCN2A is one of the most important causes of DE with a heterogeneous phenotype, and the differential diagnosis includes other sodium channelopathies like SCN80. So there is no definitive genotype-phenotype correlation existing, and phenytoin must be tried in children with early onset refractory epilepsy awaiting genetic confirmation. Thank you.
Thanks, Dr. Monica. Any comments from Dr. Sangeeta, our mentor?
Yeah, thanks, Monica, for the nice presentation. So here we just wanted to emphasize that SCN2A is one of the common causes of genetic epilepsy, and as Monica was discussing, the protein is widely expressed in the brain, including cortex, hippocampus, striatum, and midbrain. So this can explain the clinical spectrum. So that the children with SCN2A epilepsy not only present with epilepsy alone, they can present with unexplained neurodevelopmental disorder, like an autism spectrum disorder without epilepsy as well. And many of these children develop movement disorders as well, complex movement disorders, including dyskinesia, scolioarthrosis, and ataxia. So more than 50% of children have onset in the early infancy and as well as in the neonatal period. So therapeutic trial with phenytoin must be considered in neonates and infants less than 3 months of age with refractory seizures. So gain of function mutation usually have good response to phenytoin, though the loss of function mutation may not show response to the phenytoin. So this is a carry home message which we want to convey. I would like to invite expert comment from Dr. Jitanki and Dr. Biju.
Dr. Jitanki, yeah.
Thank you, Dr. Monica, and thank you, Dr. Sangeeta. I think there were two excellent cases. Just a point only. I think I agree with all your findings and also the phenotypic variability in the presentation. And also just one other, consideration of patients who have these frequent seizures and loss of, language would be GRIN2A mutation, where they also have a spectrum of language regression. So just a point, additional point, a similar presentation would be GRIN2A mutation, but I am not sure whether there is any association with febrile illness, like in the case that you presented in the first case. Whether there's any associated link with febrile illnesses.
Thanks.
We have done the whole exome sequencing for both the kids. We haven't identified any mutation in the GRIN gene.
Dr. Biju?
Nothing in particular, but I think the take-home point is the fact that the gain of function mutations are more common in the younger group, and particularly in children, as Sangeeta said, in the first 3 months of life, you should be prepared to use sodium channel blockers. I think that's a very important point.
Thanks, Dr. Biju.
If I may add just one point, I think the use of supratherapeutic doses is what we need to emphasize as well, because we may not achieve the response if we use, in the normal doses. So it's important that if we, particularly like now, if you have the mutation readily available, you'll be considering that. But when the patient, the clinical spectrum, specifically in the infantile presentation, the use of supratherapeutic doses is important for us to achieve the control.
Thanks, ma'am. Dr. Monica's questions on SCN1A. There are a few reports. SCN1A gain of function may respond well to phenytoin. And what is your comment about that? Hi, are you there?
Yes, sir.
So
Questions
for
on
SAN,
SAN?
for SAN
No.
1A epilepsy, generally we tend to avoid phenytoin. The drug of choices which we use commonly in practice are valproate and combination of valproate or topiramate or zonisamide with benzodiazepine. And refractory seizures presenting with a Dravet-like phenotype, we have used tiripantol. We have no experience with using phenytoin. Do you have any experience with usage of phenytoin in SAN 1A epilepsy, Dr. Jitangi?
No, we have experienced increased seizures. We would expect increased number of seizures. No, not really.
Okay, if there are no further questions or comments, I will move to the next case. This one is from Dr. Zubin Shah. He's an epilepsy fellow from Dr. Sandeep Patil Center, Pune. Yep. Over to you, Dr. Zubin. Yeah.
1 minute. Hello.
Yes, we can hear you. Yeah, go ahead. 8 minutes starts now.
Myself, Dr. Zubin Shah. I'm a DM neurologist and currently a postdoctoral fellow in epilepsy. So I'm going to present a very interesting case of nocturnal epilepsy under the guidance of Dr. Sandeep Patil, sir. So we have a 4-year-old right-handed girl that presented with a recurrent history of nocturnal events. Her seizure started at the age of 6 months. In her semiology, she wakens up from the sleep. There is change in behavior, there is fear, agitation. She reaches out towards her mom. There is some bizarre kind of movements involving her both upper limbs and lower limbs. There is some living away behavior, and the event ends abruptly without any post-ictal deficit, and she goes back to sleep immediately. Such episodes are present only during sleep. So the 90 to 95% episodes were present in sleep only, and the duration was 3 to 5 minutes. And according to her parents, some of the events were lasted for 20 to 30 minutes, that long. Her initial frequency was once in a 2 week, but gradually that increases, and presently that is almost daily. Her birth history was normal, developmental history was normal. There was no abnormal behavioral history. Her family history, no similar findings present in her family members. There is no any history of consanguineous marriages. There is no history of trauma, encephalitis, and febrile seizures. Her neurological examination was completely normal. So to summarize, we have 4-year-old right-handed girl born out of non-consanguineous marriages with normal birth and developmental history that presented with paroxysmal nocturnal events since 6 months of her age, with gradual increase in frequency without any family history. So at the current point, we had 2 differential diagnoses, that is frontal lobe epilepsy that can present during night time, but the episodes are quite prolonged for frontal lobe epilepsy. So the another possible differential diagnosis would be parasomnia. She was evaluated outside. Her EEG, MRI was normal. She was put on anti-epileptic. Firstly, she was started on oxcarbazepine, but her events were continued. So on her second visit, the clobazam was added. But despite on 2 ASMs, she was continuously having episodes, daily episodes. So she was referred to a center. So we thought, what should we do next? Either change medicine or further workup, because at this from history, it seems like frontal lobe epilepsy. So anyways, we proceed towards the video EEG recording. She underwent 48 hours video EEG recording, and we recorded multiple events. This is her awake record. We can see background activity of 5 to 6 hours. There was no ID in her awake EEG. This is a sleep record. We can see the spindles, K complexes, and also there are no any IDs in her sleep record too. So I'm going to play her event. So she wakens up. There is involuntary movement started in her both upper limbs. That was some like chorioacetoid movement involving proximal as well as distal movement. We can see her some neck movements also in this video. Now her legs are also moving. So she is completely aware during such episodes. We have also tested her, and she was found to be completely conscious. We can see some perioral movement also. Now the intensity of movements is also increased. We can clearly see the perioral movements also, neck movement, arm movements. So basically, this is a chorioacetoid movement. These are 20 seconds before her ictal onset. We can see the sleep recording. Now that is 8 seconds before, and she erupts into such episodes. We can see the muscle artifacts and no clearly ictal evolving, no evolving rhythm is present in that. This is our movement artifact. We carried out 3 Tesla MRI also. This is coronal T2, axial T2, flare. This is T1. MRI was also normal. We also done PET brain. That was also normal. So now we have all the 3 investigations were normal: EEG, MRI, and PET scan. So after seeing, we came to 3 main differential. Our first differential was this kind of some movement disorder, that is PMKD, paroxysmal non-kinesogenic dyskinesia. Because the movements were quite chorioacetoid movements, we can see her proximal and distal, very dancing-like movement. So we kept this possibility first. For frontal lobe epilepsy, the seizure, the episode was quite prolonged. Some episode we record some episode for 15 minutes also. So that is quite red flag for epilepsy, and she is completely aware. And that is, episodes were also not stereotyped. And the third, parasomnia. For parasomnia, the patient is completely aware. That is also some odd points against parasomnia. So we were going some literature, and we come across some anti-T ADCY5 mutation. So in ADCY5 mutation can present from infantile onset to adult onset. And we can see in ADCY5 there is a myoclonus, dystonia, chorea, acetoid, and combination of such movements. And for ADCY5, those episodes are particularly present in night. In some patients, some babies, we can see the axial hypertonia as well as language delay. Though we could not find any axial hypertonia or speed delay.
Dr. Subin, 1 minute more.
Yes, sir. Yeah, we could not find any such features. We advise our parents to go for whole exome sequencing, but they were not affording. So to keep in mind the ADCY5 mutation, we go for the treatment of this. The treatment is very simple. That is caffeine only. So we order caffeine tablets from the Amazon. It is available in 100 mg dose. We gave her 1/4 BD, that is 25 mg BD. And surprisingly, she tolerated it very, very well. And her episodes were significantly reduced. Last month, she came to follow up. The episode she got only 1 episode in the sleep. So the dose of the caffeine can be 60 to 800 milligram. And the tolerance level is for high doses is quite low. But in low doses, the effect is also good. That is 80%. So that article published last year with a case series of 30 patients, and the efficacy rate was 80%. The half of the patients were from France, and that was a multi-center retrospective study. So last week, we finally able to send her whole exome sequences. The report is awaited.
Zooming time up. Yeah.
Thank you. Thank you.
So, Dr. Sandeep.
Let him, Ranjit, before that, let him finish his take-home message, I think. Which बोल रहे थे बेटा? Tell the take-home message.
You can show your take-home message.
Take-home message. You show the take-home message. You should say.
So the take-home message is.
Yeah.
So the take-home message is that for such kind of episode, we need to record such episode from video easy. So there are always three possibilities we should keep in mind. Before stamping it is frontal lobe epilepsy, we should keep in mind that is whether it is parasomnia, whether it is some kind of movement disorder. So video EEG that helps in certain cases. That's it. Thank you.
Dr. Patil? Dr. Sandeep Patil?
Yeah. Yes. Thank you, ma'am.
Your match is over?
And
Match
good
over? Match over?
Yes, ma'am. Match is over.
I see. Match is over. You're back home. Okay. I thought you were in the stadium
Back
still.
home. Yes,
Yeah.
ma'am. Back home. Okay. So, thank you, Zubin, for an interesting presentation. And uh, only two messages I want to convey with this case. Basically, the first message would be if someone who has got recurrent events, despite on appropriate anti-epileptic drugs, to capture those events either by because I saw this patient in a peripheral visit, and they gave like they have shooted a video, and by looking at the semiology, I got the feeling that something is not right because it's a lot of movement disorder kind of stuff. Like she had a dystonia, chorea, and it was not fitting. And obviously, the closest differential was a frontal lobe epilepsy, like frontopolar epilepsy, where you have a lot of hyperkinetic movements, and they happen through the sleep. So that's why we thought maybe it would be interesting to record the events. And when we recorded, as Zubin rightly showed, there was no ictal correlate. So that's why we reviewed the literature and thought maybe it could be a movement disorder. And we are into precision medicine era, and probably we thought, see, ordering caffeine was quite easy for family. We just ordered through Amazon, and we started on a very low dose, and she responded really well. So that's why we could not send genetic study. So we thought maybe give a trial of caffeine and see. So I think any kind of seizures or movement disorder, capturing the event is very, very important to confirm the diagnosis. That would be the take home from this case. Thank you.
Thanks, Dr. Sandeep. Any quick comments from Dr. Jitanki? Because we are almost
Thank
like
you. Thank you, Dr. Zubin, and hello, Sandeep. So excellent case. I think what I would like to again reiterate is what Sandeep mentioned. It's a rational approach. When we have a patient, the three main differential diagnoses that we would consider in this repeated type of stereotypic events which happen in sleep. So movement disorder, or is it related to frontal lobe epilepsy or parasomnia would be our main considerations. And I think Dr. Zubin, indicated from the history, it sounded more like a frontal lobe epilepsy. And I think, particularly the hyperkinetism and also the frequency in sleep and also the leaving type of behavior. But then when we looked at the video, we could see that it's clearly a movement disorder, and also the persistence for a long time raised concerns of movement disorder. Just one point would be like, in our case where we don't have the genetic mutation, like looking at it, I would have considered paroxysmal hypnagogic, dyskinesia. So it's interesting for me to hear about the use of caffeine in the mutation that you mentioned. But then I guess we would anyway use caffeine in an attempt to see whether that would sort out the movement disorder, even if we didn't have the genetic mutation. So it's a nice case. I would actually, I want to ask you, do you think, we would have the same response in PRR2 mutation with caffeine? Is it just that, in the mutation that you mentioned that they describe caffeine?
Nice question, because I actually initially thought of PRRT2, and that's why she was on a oscarbamazepine, and I actually went up to 25 to see if at all she requires higher dosage to, because PRRT2 should respond to sodium channel blocker, carbamazepine or oxcarbazepine, but she did not respond. And actually, I thought of channelopathy and given flunarizine also, potassium, calcium channel blocker, but that also she didn't respond to that. So the caffeine was, cheaper and easy alternative. So we tried that then. Yeah.
Dr. Biju?
Very interesting case. The movements on the, of course, whenever you see any paroxysmal dyskinesias, you should always think of the frontal lobe the seizures. But on the videos, I didn't think it was hypermotor, the sort of hypermotor that you would associate with frontal lobe. But when it comes to paroxysmal chorioathetoid movements in sleep, I think the first possibility is like, as Dr. Jidangi said, the paroxysmal hypnogenic dyskinesia. And then, of course, the paroxysmal kinesogenic, non-kinesogenic, and then the exertion-induced dyskinesia, as you want to say at night. But with the ADC Wi-Fi ones, it's not a primary sleep disorder, isn't it? And you can also see it with even with non-epileptiform situations. And often the sleep is very disrupted. And these children with the ADC Wi-Fi mutations, often when they wake up in the morning, it is these movements are particularly worse on waking up, which is thought to be due to the disrupted sleep caused by these movements. But again, it's interesting to think about this, and of course the other one would be GLUT1, isn't it? SLC2A1. So interesting that we should think about this, particularly with the dramatic response to caffeine. But I don't think it can be considered as a sleep disorder as such. It's a movement disorder which causes disrupted sleep with worsening of the movement disorder in the waking up. If you get that in the history, then you should think about ADC Wi-Fi, I think.
Yes.
Thanks, Dr.
Of course, DBS. I don't think DBS. People have done DBS on these children, but I don't think with very incomplete responses. I think I haven't heard of any successful things. I suppose we haven't had many cases anyway, and they often respond very well to caffeine. So, and it's thought to be the dysregulation between dopamine and adenosine, which is the reason for these movements and why the relationship with sleep. So
Thanks, Dr. Biju.
I
Dr.
think Ranjit, once again, I think this is a wonderful case, wonderfully presented, and it reiterates that your history taking is not redundant. It's very important, and the semiology of the seizure or the description of the event, whatever, on a video recording, because most of us have mobiles now, right? So I think that is very important. I think that what made you think, Dr. Patil, right? From the thing. So that
Yes,
becomes
ma'am.
very important. Yeah.
exactly.
Thank you.
Because if it is just paroxysmal hypnogenic dyskinesia, then they often respond very well to antihistamines even. So but you have to think of something in order to try something else. So very important. Very good.
I think you've had interesting cases today, right?
Yeah.
Dr. Biju, just about what you mentioned about ADC Wi-Fi, do you find that they respond to acetazolamide as well?
I think some people, I think in the last Neuro Exchange, I think somebody asked John Ming the same question. I think people have used it with some response. And with the paroxysmal hypnogenic dyskinesia, also people use acetazolamide with good response. So, but
I think,
caffeine
but
works
for
better.
Yeah, ADC Wi-Fi, what we got is, I think, two reports. The one is what Zubin is presented. This is a French group report, and what they have found is it's almost 87% response to caffeine. And I think there was one from Middle East or something. So that was presented in ICNC last conference. So
That's the one from Anjali, Dubai, Muhammad
yeah,
Babika's
Dubai.
case. Yeah.
Yes.
So,
Ranjit?
Yeah, let's move on to the last case quickly. This will be presented by Dr. Shakshi. The guide is Dr. Prashant Jowhari, and this is from AIIMS, New Delhi.
Is my screen visible, sir?
Yes, go ahead.
Good evening, everyone.
You are not, you are visible now. Yeah. थोड़ा नीचे कर. Your head, it's okay now. Yeah, fine.
Am I audible, ma'am?
Start,
Yes.
it's all through. Perfect, yeah.
Good evening, everyone. At the outset, I would like to thank AOCN for giving us this opportunity. I would like to present a case of a child with epileptic encephalopathy. So,
It's not moving, you can stop share
yes,
and then
ma'am.
share again.
Yes, ma'am. Yes, ma'am.
You can reshare your PowerPoint. Hello.
Move to the next slide.
It's not moving, ma'am.
You want me to share?
Yes, ma'am.
Ma'am, you can share me. I'll drop my email ID in chat box. Quickly, you can share me on this.
You can allow me to share the screen, I think. Okay. I shall share her slides.
Okay, ma'am.
दोबारा ट्राई कर लो. एक बार कर लो. Then I'll
Okay, ma'am.
Click on the enter, double enter. See on bottom, you have two options, left and right. Click on that.
Yes, ma'am.
Yeah. Yes, right. Click on
Okay. Yes. So, a 7-year-old, typically developing boy presented to us with complaints of abnormal body movements for the past 3 years, progressive loss of speech for the past 1.5 years, and abnormal behavior for the past 1 year. The child was investigated at around 5.5 years of age. The MRI 3 Tesla epilepsy protocol was done and it did not show any structural correlate. An EEG was done outside, which showed near continuous spike and wave discharges, and a clinical impression of Landau-Kleffner syndrome was made. The child was started on anti-epileptics at the age of 4 years, valproate, levetiracetam, and clobazam, with a gradual hiking in their doses. At around 5.5 years, a trial of IV methylprednisolone pulse was given. 2 pulses were given in a gap of 1 month, and the dose was around 30 mg per kg per day over a period of 5 days. Along with this, oral steroids were started, which were gradually tapered over a period of an year. The child also received a trial of IVIG at a dose of 2 gram per kg. Although the clinical seizures stopped, but there was persistent aphasia with gradual worsening to a point of complete mutism. Also, the child started having abnormal behavior in the form of hyperactivity, aggressiveness, irritability, and wandering. So, at this point of time, the child was referred to AIIMS for further evaluation and management. We did an EEG for the child. This is the baseline EEG of the child. And we can see here there is no discernible background with absence of sleep markers. there are almost near continuous high amplitude spike and wave discharges showing phase reversal at T4 and T5, T3, T5, showing bitemporal discharges with spike wave index of around 80 to 85% in sleep, and the spike wave index in awake state was around 10 to 15%. So a diagnosis of epileptic encephalopathy with ESES, now being termed as developmental epileptic encephalopathy with spike wave activation in sleep, was made. At this point of time, as the child had already received multiple courses of steroid, we opted for an alternative modality in the form of non-invasive neuromodulation. So a protocol of repetitive transcranial magnetic stimulation was made for this child. The protocol was an inhibitory protocol at low frequency of 0.5 Hz, and the stimulation site was CZ. Total 3 cycles were planned for this kid at week 0 for 10 days, at week 8 for 5 days, and at week 12 for 5 days. And each session lasted for 40 minutes. CZ was chosen as a site of stimulation in this particular case, looking at the previous available literature, where people have tried vertex suppression in refractory epilepsy with either diffuse epileptiform foci or multiple foci in order to suppress the supplementary motor network which is just beneath the vertex. This is the follow-up EEG which was done 1 month post the last session of RTMS, and we can see here this is a beautiful sleep record showing all the sleep markers bilaterally symmetrical and synchronous. And to our surprise, no epileptiform discharges were seen at the end of 16 weeks. On the behavioral profile, the VAP score also showed significant improvement in all the 3 domains. We can see here the initial score was around 158 and post RTMS score was around 209. A child who had never been to school has now started reciting poems and started to learn simple calculations. As far as the resting motor threshold is concerned, which was taken at the left motor cortex, at baseline the RMT was calculated as 88%. On follow-up at 16 weeks, the the RMT came down to 68%, showing a significant disinhibition of the cortex. As far as the normative data is concerned, the data at our lab shows a RMT in the range of 50 to 55% in this particular age group. The FDG PET scan, which was done at the baseline, shows hypometabolism. We can see the red bold arrows here and the green areas. So hypometabolism was seen in the bilateral medial prefrontal cortices, in the anterior cingulate cortex and the posterior cingulate cortex, as well as the medial temporal lobes. On the follow-up PET scan, we can see there is significant reduction in the hypometabolism noted in the above mentioned areas. Basically, these areas forms the default mode network, both the anterior and the posterior default mode network, and thus explains the remote inhibition seen in cases of refractory epilepsy or epileptic encephalopathy, which can be seen with this PET study. This particular case was a part of a single arm intervention study which was done in children between 5 to 12 years of age who were steroid refractory or non-responsive as a part of DM thesis under the able guidance of our mentors. Thank you.
Thank you, Dr. Shah.
Prashant. Dr.
Good
Prashant.
evening, everyone. So, Sakshi has beautifully described this case. I would, in fact, would love to have queries and comments, and maybe from our experts. So, recently, over the last few years, we have been working with transcranial magnetic stimulation in epilepsy and trying to see what is the diagnostic implication it has, as well as some therapeutic implications. So, there are certain protocols that can be therapeutic as well. So one of them is an repetitive RTMS, the other is a theta burst. So we are trying to develop and see even whether this can be a fruitful therapeutic modality in our patients with drug refractory epilepsy. Some of our work is majorly on focal lesional epilepsies, but this was one case which was there was no specific target that we had. So there was a non-targeted stimulation that we chose. It depends, and searching the literature, which shows CZ. There could be other sites as well. So let us have comments from all the experts. And
There was one question, like, have you tried ethosuximide in this child? Like, there was one question.
Okay, so we do try ethosuximide in few of our cases, and there's a mixed response. Some show some certain degree of response, others don't. But in this particular case, we did. We do try topiramate, pirampanel, and ethosuximide.
Ruchitangi. Dr. Viju.
Thank you to the present and congratulations, Dr. Prashant and Shefali. Actually, this is the first time I have heard of this, so I have basically no experience whatsoever. So very interesting to hear about your response. But I would just want to know whether you actually considered looking for the genetics, just simply because of the age of presentation and also the epileptic aphasia syndrome, whether there was any underlying epileptic, any mutation, and also did you consider, high dose benzodiazepines as a treatment option in this patient before you ventured into TMS? So I actually have no comments because this is actually new news for me.
Thank you, ma'am. Thank you. You had a valid question. So generally, we go ahead with a trial of anti-seizure drugs before we think of steroids in these patients. So generally, the trial would consider of a combination of a benzodiazepine along with valproate majorly. So the trial is generally given for 3 months, and if there is no change in behavior or the EEG, we start with immunosuppression steroids as the primary standard of care. This is what we follow in our institute. And once the kid relapses or there is a failure of that, then we think of other modalities like other anti-seizure drugs, which Ranjit mentioned, like ethosuximide, topiramate. But there's no standard protocol, ma'am, for this. Even steroids, if you look at literature, we don't have a standard protocol saying that you actually pulse. Majority of the Western colleagues, they don't use such high dose of steroids in children with CSWS or ESIS for that matter. So we did give clobazam in this child, but I'm not sure what you meant by high dose. We generally go up to say 0.5 to 1 mg per kg, not beyond that, because then it causes significant sedation. So we would not want that to happen. And so that is what our protocol is. So we do that. And did I miss any part of your question, ma'am?
No.
So this is how we go ahead. And TMS was we were actually looking at see what it does is that it creates a short-term inhibition. So depending upon the type of protocol you use, you can actually inhibit or stimulate the brain. Now the problem is that it is a superficial non-invasive stimulation, so it doesn't go very deep. So if you have a neocortical epilepsy, the chances is that, and if you are hitting it properly, then maybe you will get some benefits. But what we have also learned with our experience and the experience that people have on depression, the site which is causing depression is quite deep, and still it is an FDA approved therapeutic modality there. So how it is happening is that there is a connections that epilepsy is a network, so what we are trying is to hit some additional nodes, hot nodes that are there in that epileptic network. And maybe it works in some cases where we are able to hit that network. And then there are some biological proofs of that based on the PET findings we had, and some other non-therapeutic parameters on TMS itself that shows that yes, there was some inhibition of the default mode network, which post-steroid in some other studies and in post-RTMS in this case actually elevated that inhibition, and maybe that is the reason why you get better improvement in the behavior and cognition, but it doesn't happen every time.
Thank you. Just wanted to say that, we are in the division, we have been working on various conditions in which we are trying to use this TMS, because it's been done in hemiplegic asymmetric CPs, and, we have been doing in TMS and autism spectrum disorder, dystonia, currently studying autism has been positive study, and SLD we have started now. So, I mean, it has a lot of scope actually. So that we are trying to develop. Dr. Biju.
Dr. Shefali, we don't use it, but as you know, like we've been discussing this, the use cases. This particular one is very interesting. Now, I mean, theoretically, as Prashant was saying, it certainly makes sense. Particularly, beta bursts can suppress the cortical excitability, and I don't know whether it was opposing the hyperexcitable state or inducing reducing the cortical excitability. The FDA approval, Prashant, is that's for cortical mapping, and also for in epilepsy, it is for cortical mapping.
So it is not for epilepsy. I was saying that it is an
depression
approved therapy for depression, OCD.
For long, long back.
I think it is also approved for pre-surgical cortical mapping.
Yeah, it is there. So as far as epilepsy is concerned, the brain mapping, the mapping is the only way, and language localization to some extent. That is the use that we had initially for TMS in epilepsy.
So is it easy to get past ethics with this one, as in terms of using it?
Yes.
So this generally showed that now data is available on safety over 2.5 years. So we had that opportunity of doing a few more studies. One under Shefali ma'am was done on hemiplegic CP. So there we didn't find any alarming side effects. And one that we have completed was an RCT on focal lesional epilepsy. So there also we didn't find it precipitating a different form of a seizure or a status. So that way, because of that, so we were able to get the ethics approval for this. So and
you had a sham control as well?
For this study, we didn't had, but for the previous study that I was talking about, that RCT, that had a sham control.
Yeah, the focal lesional epilepsy had a sham control, as well as the hemiplegic CP had a sham control. ASD also has a sham control.
This was a single arm intervention study.
And this was TMS along with EEG, isn't it?
No, EEG... it is not EEG co-registered with TMS.
Okay.
So that is a different thing. It requires a different setup, a device.
We don't have that
costly
machine.
And for resource constraint. We have been, ma'am is trying very hard to actually procure that, but till now we have not been able to. But this is it is just done separately there. So we did an EEG which showed that there is an abnormality, and we repeated it. So, but this dramatic response is not there in every case. The mean change would be somewhere around 20 to 25%. Of SWI.
How long was this sustained for, the effect?
So that is what the true reason why people have objections or reservations for this. But studies have shown that if you sustain this for some time, then it leaves the post-stimulation period also, you can have an effect. So in our experience, believe me, there are kids who have been seizure-free for 6 months and more than that. But for that, what we have done is that we have used multiple cycles here. So in that previous study, we saw that majority after 8 weeks, the EEG and the seizures would restart. That is why here we have give a short cycle at 8 weeks and supplemented it with another cycle at 12 weeks. So by giving these 3 cycles, we were able to have this control. So by 1 month after that also, there was a control which is there. So almost 50% of this, in the end for this study was 20. So 50% had this clinical and EEG response, which was there. So,
but the only thing is protocols are not well defined. We have been developing our own protocols and adjusting and adapting.
Yeah. And this was a repetitive TMS, isn't it? Not not paired pulse or single pulse. It was repetitive.
So paired and single pulse are for diagnostic evaluation.
Yeah, for mapping and
For mapping, even for knowing the
Yeah.
cortical excitability. So what we have tried that and seen that in children with ESES, what is happening is that there's a remote inhibition of a lot of areas, and default mode network is one. So we proposed, and this was based on other literature also, based on PET and FMR studies, that in this the junk of the behavioral issues is not because of the heightened epileptic activity. It is because of the suppression of some major areas which are involved in our day-to-day function. So if there is any therapy which elevates that, so with your TMS, sir, you can actually do a real-time measurement of this. So you can show that the cortical excitability is this much. So in this case, it was 88, the resting motor threshold of the motor cortex, which is distant from the CZ site, or maybe is distant from the targeted site when you are doing a targeted stimulation. So that was probably inhibited because of the epileptic focus. And with time, there was a disinhibition of this, and it was nearing the normal. So in our labs, we have seen that for a normal child with a figure of 8 coil of 125 B65, the coil that we use. So it also depends upon the coil. You have to standardize that. If you have standardized that, so based on that, we get a RMT somewhere around 50, 52, 58, 60. This is the range in which we get that. So here it is getting towards normal. Of how long it is going to sustain, we need to see that. Maybe if it is showing.
Because if it works, it's a very interesting modality, isn't it? Because of the non-invasive nature.
Yeah.
Do you also use TDCS in your lab?
No, we don't have TDCS.
We don't have now, but
it's
this
cheaper
was less,
actually.
It is cheaper, but this is less painful for the kid. This is less painful.
We didn't know, actually people are doing TCDS, but we have not done. We went to TMS directly. I think that is, and what with autism and all also, it's working and it's showing benefits. So it seems to be some potential there. Yeah, I think we would now request any of our panel, our SIG members would like to say anything from the epilepsy, and then I will request the experts to say one final message. And before that, I want to thank all the presenters and their mentors for amazing, constellation of diverse cases we had today. So anybody from the SIG panelist, or SIG members who are in the panel, anybody wants to say something? Sujata, you want?
Yeah. Dr. Shefali, I think this is a wonderful program. Today, such interesting 6 cases. You could not take your eyes off or your ears off the Zoom session. And thank you so much. We have all learned a lot. I'm sure each one of us feels that way. And the presenters were excellent. Their slides were wonderful. I mean, it was really very, very
Sujata,
thank you.
student ke bhi student hai, so I feel so second generation. I feel like a grandmom,
Yeah, but amazing. Very, very nice. It was really very, I'm sure all the participants must be feeling it was something.
They'll be getting certificate. They'll be getting certificate. That's all. And otherwise, if ICNA gives us money, we'll give them money.
Yeah, no. I'm saying
we
the
are resource
restrained. Who attended also, I will definitely go back feeling very enriched today.
No, and
we
do have it all recorded, and we have in a YouTube thing. Anybody can see anytime again. Yeah.
Thank you.
Kavita, you want to say anything? Kavita, Dr. Goraya, Dr. Patil?
Yeah, good evening, everyone. I think it was a very, very interesting and good learning, covering a whole gamut of epilepsy, right from seizure mimics to the genetics and to the newer modalities. Like, we have never heard about this TMS being used in epilepsy or in the ESES and kind of phenotype. So I think it was a great learning, and thank you, everyone, and especially Dr. Ranjit for collating from everyone. Thank you so much.
Thank you. Thank you. Now, Dr. Jitangi, take home message.
So first of all, thank you very much, Shefali and the AOCN team. It's good to see my old friends. So thank you for having me. Actually, I learned a lot. So I feel a bit jealous of what you have as well. But still, the take-home message would be, I would like to reiterate the importance of history and examination, because that's the cornerstone of our evaluations. And then sometimes even though we don't have all high-flown investigations, sometimes a good history can can become very useful and very, very interesting cases, really fantastic gamut of cases. So thank you so much.
Thank you. Thanks, Dr. Biju.
It was a very wonderful session, and nice to see Ranjit and Prashant again, and Dr. Sujata as well. Haven't seen them for a long time. So interesting cases. I particularly like the titles as well. They were all very catchy, very interesting.
Yeah,
But,
I was just thinking
exactly.
titles should be noted down. I think
Yeah.
titles should be noted down and you will put it on the website, the titles.
Particularly like the one with the Simpson cartoon on the fires one.
No, this is Ranjit's only. Dowsing
Yeah.
what fire? What did you write, Ranjit?
Dousing the,
You know,
dousing the fire.
I'll
That
tell
is
you.
going to douse
I'll
the
tell you.
fire. Yeah.
No, Dr. Biju, this all starts when we have a CCR presentation, which happens twice in a year. And I tell them, get some exotic title you make. So there's bottle, old wine, red bottle, patani, whatever. They keep making all that, some giraffe somewhere. And also they make, so they've got habituated making exotic titles. So it was very nice to see them go ahead.
I agree with what Dr. Jidanki said, history and, even with precision medicine, we can do all the genotype, phenotype correlation, but as time and again, it's proven that nothing is as straightforward as it seems. So,
And it is VUS half the times. It's VUS half the times.
every time we see an epilepsy case, it's still fascinating. So there's always a twist.
No, but your movement disorder came, so that's why you
Exactly.
came.
So
Thanks to
fantastic.
Dr.
Thanks very much for organizing it, and thanks very much, Ranjit, for hosting it fantastically well.
Oh, Ranjit
He was
is
quite,
a very strict person.
I thought at times he was a bit harsh on the time.
No,
The
you know
residents.
what, Dr. Biju, I tell you what, he forgot for one gentleman. I called him. I said his time is up. He said 1 minute is left. I said, you speak up. It is not fair for others. But he's a very
The
nice.
moment he said time is up, they couldn't then talk anything further.
No, otherwise it keeps going on and on and on. But he's a very good. You didn't attend the quizzes he did. He did wonderful quizzes for us. I had done for Academy of Pediatric Neurology, that IAP Child Neurology chapter. For the pediatricians, we did the epilepsy 16 webinars. Ranjit, 16 webinars we did for pediatrician. So all of them were teaching us for pediatrician. So they had quiz for the pediatrician, they had quiz for the residents, and they had no money for the DMs because it was meant for pediatricians. So they got wonderful quiz. I wanted them to do quiz. We got a platform in which they did. It was nice, but it was for because that was the epilepsy module for the practitioner. Yeah, thank you. I think we have crossed 27 despite Ranjit, because we went overboard chatting. Yeah. Thank you so much. Mahesh, you were silent. You were doing your practice. Now you please speak your comment. I forgot you existed. Yeah, come on.
No,
No. He was doing his practice, huh?
No.
What is the message?
Ma'am, it is a wonderful collection of cases, ma'am. Each case had a unique message. So I recognize all the presenters and their mentors, ma'am. It was a really nice collection of cases.
Yeah, and I think 5 of them were my second generation. So out of the 6, so I feel really very happy about it. But 2 feel ancient also. You can find out, Mahesh. But
Yes,
now people have
I am also, ma'am, your student. You can also count me.
No, Dr. Patil, you're not directly my student. So, I mean, the others are all yeah, everybody's a student. We're all learning. Yeah. Thank you. Thank you so much. Mahesh, bolo final.
Yes, ma'am. Next Wednesday
But
also we'll be
one
having another
thing. Sorry. If anybody has interesting DE cases, Mahesh, you can send out a mail tomorrow to have any interesting DE cases. We have a webinar on DE next time. And that's when by Dr. Hassan. So then, so I thought that if somebody sends some DE cases, so, we can select out of them and have 2 to present, and rest can be kind of, they can be asked to video record and we can put it along with the YouTube thing. That others, like if there are more than 2, then we can select 2 out of them which are there to present briefly like this after his session. We can do that. So you please send out
Fine,
a mail, and anybody, whoever is there, please, you can do. But those who presented today can't be taken next week. Okay.
Okay, ma'am.
Yeah, that will be too much. Yeah. Yeah. Thank you so much.
Those presenters today have been fantastic. They were very, very good, excellent.
Yes, sir,
Yeah,
yes, sir,
so
true.
so they'll be getting a certificate. I thought that at least we should give from our side. Anything else you suggest, Dr. Biju? But finances, we don't have that many actually. So-
I would ask them to all join Flickr.
No, Dr. Biju, I thought you were in UAE, so you can do some donation from UAE too. Thank you so much. Thanks for joining.
Thank you, Dr. Shefali. Hi,
Thanks,
Dr. Biju.
thanks. Bye. Bye.
Okay. Great.
Thank you, Ranjit. Bye.
Thank you, everyone.
Thank you all. Yeah.
Dr. Ranjit, wonderful as always.
Thank you, ma'am. Thank you, ma'am. Thank you very much, ma'am.
Bye.